So week 8, we are almost there, guys. This is 2/3 of the way through, right? Week 8, what do you have due? Well, we know it is that pediatric assessment assignment. Again, get it to me by Friday. I'll correct it, send it back, and you can give it back to me if at all possible. I can't guarantee I'm doing all of them, but I will do as many as I can. And you know, I'm pretty good at getting a lot of that stuff done. You do have some NCLEX questions due, and you do have that pediatric assessment exam, which is like a case study. Now, quiz 5 is not today. It's going to be next week. So this is for you, it's like a happy Thanksgiving present. Furthermore, those students that taking classes on Friday, which a lot of them do in the RN program, you know, we didn't want to do that and mess it up. So next week,
Yes.
your quiz will be on this week's information, okay? Did you all get the matching sheet that I sent you? It is in the announcements. It is called GIGU matching. Of course, I'm going to send the answer sheet when I
Oh,
send you
okay.
the recording tonight. But I went through the book, and what I did is looked at the big topics and I wrote them down. Just like cardiac, respiratory, I did it with GIGU. Now, GI is a lot different. There's many different diagnoses that you don't see in the adult world. So just to have them there and what do they mean, just the basic information, I have it there. That matching sheet is really good for you. So make sure that you see that. This week, as I said, GIGU, we're going to do that PowerPoint. We're going to go on for the cahoots. Again, we'll run right through. Anybody has any questions, just let me know, okay? So let's get going. A lot of interesting things. A lot of stories, of course. So GIGU, chapters 41 and 45, okay? So GU defects, urinary tract infections, is whatever you think about GU, especially with children, right? One of the most common things. It's very hard to prevent them, especially with children, potty training, etc. One of the things that creates this GU and these infections are actually uncircumcised males. A lot of mothers, and my best friend had a little boy. I had to go pull the foreskin down and clean it for her. I mean, we were bestest of friends. We lived, you know, 2 blocks away from each other, but she couldn't do it. And I know that that white stuff, that schmegma, will build up, and it's like a petri dish for bacteria. So one of the things that we can do as nurses, tell our parents, pull it down, clean it every day. Christian was so tight, called a phimosis, that I couldn't pull it down. So we had to have him circumcised to prevent, you know, these urinary tract infections. And one of the things that we always must tell our parents, especially like with strep throat that causes many different things, we're going to learn about another thing strep causes tonight. Make sure they finish all their antibiotics. Just because they're feeling better doesn't mean you can stop, because there can be outcomes in the future that are pretty horrible then to treat. So, prevention of infections, urinary tract infections. Of course, always watch your child. What are they doing? Are they urgent? Are they holding their, you know, perineal area, etc.? Of course, do they wipe front to back? Well, we know what kids do when they're in the bathroom, and then they get old enough, they close the door and don't want you in there. So are they wiping the right way, especially girls? We know bubble baths and girls are also something else that can cause them. And tight fitting tights on girls. And they say girls should be wearing cotton underwear. They've got cute little polyester and all the design things, but the cotton underwear is actually best to prevent these things. Another thing is the adolescent, teaching them, and we're not saying that they should have sex. Of course, no adolescent girl ever has sex, but just in case they do, they should urinate as soon as they can after intercourse, even older adults, because that does help prevent urinary tract infections. It gets rid of all of that extra debris. So, how do we diagnose? Well, urine culture sensitivity. We have the midstream that we do on older children and adults, but absolutely in the younger infant, we're going to do a catheterized specimen. I mentioned this before, and it's because we want to get the bacteria that's causing that infection accurate. So we treat it once, not three times, because they have no immune system, right? We don't want them to go on too far and then damage kidneys. In the premature, we can't get a catheter in there. They don't have anything small enough. So they do something called a suprapubic aspiration. They put on sterile gloves, a sterile needle, that area is cleaned, and they take a needle, sort of 45-degree at the suprapubic, and they put it directly into that abdomen. And that's where the bladder is. And they'll pull out just a little bit, could be half an ml. It's all they need, and they can do a culture on it, especially if they're showing signs of sepsis in whatever way. Also, percutaneous kidney taps are done, an infection that you can't figure out. Let's go into the kidneys and find out. Sometimes taking a Foley, putting it in there, washing out what debris, pulling that out, culturing it, ultrasounds looking for structure, and then voiding cystourethropographies. Those are usually done to those toddlers, almost preschoolers that are having those frequent urinary tract infections, and we don't know why. We've done the ultrasound. All right, maybe there's something there, but they do that voiding cystourethropography, and it looks at any structural stuff going on. It puts dye up in the bladder, up into the ureters, and it can see, is it patent? Is there any strictures, etc.? IVP is mostly kidney stones, intravenous pyelography, and then, of course, renal scans. Now, sometimes we have to do a renal biopsy. Usually, there's nothing to eat or drink. Now, depends on the age of the child. If it is a toddler, 4 to 6 hours is okay. But if it's an infant, we don't like them NPO that long. Maybe 2 hours, they might get clear liquids, or even breast milk is considered that 2 hours before procedure. We don't want their sugars to drop because it drops that quick. And we're going to pre-medicate them somehow, whether it was a little bit of that midazolam or something to calm them down, especially older children, so that we can get them in position. And then we usually use like something like a propofol or something, knock them out slightly. They stick a needle right through the back, and they go right into the kidney, and they pull out urine, and they're going to pull out a little bit of tissue, and then they're going to be able to examine that for culture, or just maybe a biopsy is what they want with it. Now, always before any procedure, after procedure, always vital signs, always make sure they're getting medicated in some manner. And then after they wake up, make sure that, their comfort is good. Now, when it's done, that has needle has entered a kidney and through the skin. So there's chances for bleeding and leakage of urine. Okay. So, what are we going to watch out for? Nursing. What are we going to do? Well, number one, this child must stay in bed for 24 hours because we want, just like a cardiac cath, for that clot to be sealed so that we don't have urine or blood, being oozed out. And we're going to watch intake and output, making sure that kidney is still working, right? And sometimes you'll see abdominal pain or tenderness. This might be your pre-warning that something has gone on. There's leakage in there and something to be looked at. The smaller the child, you might need to do the incision, and that's why that's there. These kids will be knocked out, so usually they don't feel pain. And when they wake up uncomfortable, they just want to get up and out of bed, most kids. Now, one of the things that causes a lot of problems with children is obstructive uropathy. So remember, the bladder is called a vesicle, okay? Vesicle and then ureters. So vesicle ureter, some sort of obstruction there. So just remember those names. It could be a couple on one side, could be up both sides, but if the urine can't flow down, it's going to make that kidney into a hydronephrosis and could kill it. So we really need to be aware of those things. So early diagnosis. This picture is from your book. Now, nephrotic syndrome is very, very misunderstood. So listen to this 3 times. This is not kidney failure. The kidneys are working. It is not kidney failure. What the kidneys do is they say, "Ooh, protein, yuck, I'm getting rid of you." So it takes the protein and you urine out protein. Proteinuria, that foamy urine again, right? But where does protein come from? Protein is in your blood, right? That's what medications hop onto. And the stuff that's left is free flowing in the blood, which makes your blood level. So all the protein's being sucked out by the kidneys because, ooh, I don't like protein. Let's get rid of it. So, what are you going to see? Well, it's going to be massive protein loss. It also causes how the fat levels to go up. So hyperlipidemia, but because the viscosity of the blood and the body likes isotonic. It does everything to make everything equal, like point 0.9 normal saline. It wants that equality. Well, it pushes stuff out extracellularly. And what you see is a lot of edema, like puffiness around the eyes, in the cheeks, in the tongue, in the mouth. You're going to see these kids look puffy when they're in an acute situation with nephrotic syndrome. And it's all due to protein. So, what do we need to be worried about? Well, this is not an acute thing. This is something a child has to live with, all right? So they are immunosuppressed, risk for infection. Now, their mouth is swollen, they're biting on their gums, they hurt, they lose their appetite. They don't want to eat, right? If your mouth hurts, you want to put food in there, a kid, they won't. Well, maybe we will, but a child does not. And when they're sick, kids don't eat. So it's a fluid problem now, isn't it? All this edema. How do you assess fluid in adults and children? We're going to restrict the salt and we're going to do fluid restrictions, daily weights, right? And we can measure how's that fluid going on. And then, of course, always support your family. So we're going to reduce that protein. We're going to reduce the tissue. We'll always be aware of infections and prevent it because, again, immunosuppressed, they can go into septic shock. We don't want that. And again, your priority, your nursing care, it's a fluid problem, intake, output, daily weights. Now, I started this, class tonight telling you about strep, taking the antibiotics to the end, right? Well, here is another condition caused by an undertreated strep condition. So we have rheumatic fever, and now we have acute glomerulonephritis. That means the kidneys stop working, okay? And it's due to that strep infection. Symptoms: you're going to stop urinating. So you're not urinating, you're going to swell up all over. And just like any kidney failure issue, high blood pressure. You might see hematuria and you're going to see protein squeezed out. So we know usually this is acute because it's from a strep infection. So we treat the strep infection, we give antibiotics, right? But if it wasn't caught quick enough and not taken care of quick enough, or the immune system was not strong enough, some of these children will be chronic, but most of them can be turned around. So, daily weights, intake, output, it's the kidneys, it's the peritoneal cavity, measure the abdominal measurements, and of course, low sodium fluid restrictions and washing hands. That means susceptible to infections and teaching the whole family about it. Now, Wilms tumor is interesting. I had never seen it. I had just done some sort of module that they made us do as nurses, to keep your, practice current, etc. It's like 6 new modules. One was the kidneys, and it was Wilms tumor, and I did it but didn't understand it. And then I got this little 3-year-old boy right after the Haitian earthquake, and our Miami Children's went down there. They found this boy, And then a religious group somehow got him transported on a plane because he wasn't sick. He just has this tumor and brought him over to Miami International. This religious group picked him up with these medical records, all in French, and brought him to me. And I said, "So why is he here?" And they go, "I don't know. They just here's the papers. They told me to bring him directly here to Miami Children's." I said, "Okay." So this is what you call using your assessment skills, right? So somehow, some way, I made the kid comfortable. And I made him feel like I wasn't threatening. I did a set of vital signs and he was relaxed. I ended up listening to his chest, his heart. I went to his abdomen and started feeling his tummy. And on the left lower quadrant was at least a softball sized tumor. And it hit me. This is a Wilms tumor. It was African American 3-year-old male, and it fit right into what I had just learned like a couple weeks earlier. And it was. So what they did was an X-ray and CAT scan of the abdomen. They found it, and they ended up doing some chemo on the kid, and then they removed it. Now, one of the things about Wilms tumor, once you palpate it, no one should ever be touching this thing over and over and over again. It's very fragile, and little micro pieces will be burst off and it cause metastasis. So they do not even do biopsies on this to make sure it's a Wilms tumor. They see where it is, they see the presentation, they go, "This is Wilms tumor, and this is how we're treating it." And it was exactly that, a Wilms tumor. So over the bed, on the chart, everywhere, do not palpate the abdomen. And at 3, being in a new country, he had to be in diapers. He didn't know how to communicate, right? So even changing diapers, these nurses had to be careful. He's actually sent the nurses through an interpreter when he finally got back to Haiti that he was doing well and told them thank you. And they got that message down to the emergency room where I was working. So I thought that was pretty cool that we saved this little boy from Haiti because of our earthquake. Now, renal failure, kids can have renal failure. It can be acute or chronic, and usually it is due to a congenital anomaly. But if you have chronic infections and you're chronically hurting that kidney in some manner, it can become chronic. It could be that structural thing. So, acute renal failure is when something happens that causes your kidneys to fail. I had a friend who took too much Advil, ibuprofen, and it caused him to go into acute renal failure. He was in the hospital. Yes, he was older, but kids take NSAIDs, right? So he got in the hospital. His BUN was 50 and his creatinine was 12. He hadn't urinating, and that's why he went in. 3 days after he was admitted, they were about to put in all this stuff to do dialysis, and he started to urinate. And then they realized it was due to the ibuprofen. So, that's one thing that can cause it. And of course, there's other things that can happen. But in children, the biggest reason for the cause is dehydration. Having a kid that is having every sign and symptom of dehydration, we must take it seriously and we must treat it and give that bolus IV fluids, get it in them, because we need to get everything in the body perfused as well as we can. Now, chronic renal failure, they say kidneys working 50% or less, and then it gets worse and worse and worse over the years. And we know those children, as they get older, are going to be needing, the dialysis. It could be due to those urinary tract infections, like I said, or some of that reflux stuff, and it kills the kidneys. Hereditary. I went to the dialysis unit and I said, "Why are all these kids in dialysis? I didn't realize." And they said there are some cultures that marry within each other, like second cousins, first cousins marrying. And that caused that to happen. And I was like, okay. So I just wanted to know. So, if I want to know, I'm going to ask. Of course, anaphylactoid purpura and lupus will kill anything, right? It's that body immune system attacking the organs. Managing chronic renal failure, we know that they're going to be on dialysis. They know that their erythropoietin is not producing the red blood cells. So we'll probably be giving erythropoietin injections so that they have to have less blood transfusions, okay? And kids, always, anything a kid has, we're going to try to make them say, be as normal as you can. But we know 3-4 days a week they're going to be dialysis. School's going to be a part of that, etc. So it's hard, but we can try. Now, young infants born that don't have kidney failure cannot go on hemodialysis. The flow of blood going in, not out, in causes this turbulence, and it can cause intraventricular hemorrhages. So if they're bleeding in their brain, which can cause a lot of cognitive delays. So, and they're doing this a lot in the adult world now when they're just diagnosed with kidney failure. They're putting them on peritoneal dialysis. And this picture is great because that's exactly what it looks like. It's a catheter into the abdomen, and it's usually, this special tip to prevent stuff from going in. And everything we do with that catheter must be sterile, as in we as nurses, and I was taught how to do peritoneal dialysis, you have to be in sterile, including hats and gloves and masks, and gowns, making sure that we're not entering any bacteria because that's the only thing they have to produce urine. So what they do on a machine, and they can do this at home, usually at nighttime when the baby's sleeping, or the adult is sleeping. They put them on a peritoneal dialysis machine, and there's liquid on a warmer. So warm stuff called a diastolate is inserted into the abdomen. Now, an infant might have 100 mLs go in. And what they do is they put it in and it stills, which means it sits there, usually 20, 30 minutes, depending on whatever nephrology says. Then they drain it, and it drains into a Foley catheter. And it might be 8 to 10 cycles of put it in there, let it sit, drain it 10 times overnight. When the morning comes, you subtract the number of cycles, which is, let's say it's 100 times 10, which would be 1,000 mLs. What is in that Foley catheter? Is there 1,500? Is there 1,200? The difference would be the amount of urine output. And again, greatest concern, peritonitis. So nurses, what do? You're going to make sure you look at the drainage color. What does it look like? Is it full of something? If it changes color, there's usually a problem. We know the chance of peritonitis is huge. So when in doubt, give antibiotics, but you need to call the doctor. You can't give antibiotics without a doctor's order. And what's great about peritoneal dialysis, it's at home, it's at night, and they don't have to go out how many times a week, bringing their child wherever. So what best describes acute glomerulonephritis? What do we got? How does a glomerulonephritis occur? Nobody?
Would it be B?
Is the answer C?
It is because of a strep infection. Absolutely. So we have rheumatic fever and we have glomerulonephritis, two things caused by strep. All right, let's go into GI. GI, mouth to anus. So it's all of the above, right? We know there's nutritional disorders. We know there's vitamin imbalances. Think about cystic fibrosis. Think about celiac disease. All of these things, they don't absorb the vitamins that they should. So remember that. So mineral imbalances. Some children, failure to thrive as we find this. And then there are certain conditions, cancer, HIV, sickle cell, cystic, and very low birth weight. And very low birth weight is there because we have to give maximum nutrition in the smallest amount. So, whereas a normal infant would be having 3 ounces every 3 hours, they might have 10 mLs every 3 hours. So, you can see how we have to pack things differently. Celiac is the small bowel where it absorbs food. The enzymes go in there, and it's the cilia are there, and it helps with the absorption of food. Well, the problem is if we do not eat good foods, no wheat, rye, barley, oats, any of these flours, anything covered in flours, chicken nuggets, noodles, all of these things. Oops, sorry. Something happened there. I hit something. We know that if we don't eat the right things, what's gonna hold on. I saw what happened there. My nail hit something. Anyway, so with celiac disease, if we have wheat, rye, barley, oats, anything with it, it creates the body to go and just it doesn't like it. The cilia get to the point where they're not going to be absorbing food, especially fat. So all your fat soluble vitamins are going away, and this stool is going to be pale, bulky, and the most smelliest things you've ever smelled. They're because the nutrition is going away. So, how do we treat celiac disease? It is diet. All diet means gluten free. So, on a gluten free diet, we're not going to have anything with bread unless it's made with rice flour or a different flour. And these kids today are really lucky because places like Publix have that stuff now, and it's written on it gluten free. Well, think about 20 years ago, it wasn't there. No, it wasn't understood. But fruits, vegetables, chicken, any dairy they can have, herbs and spices, etc. But there's plenty of things these kids can eat. And today there's so many supplements. Now, food allergies are actually big. Christian is tree nuts. You put like a walnut next to him, a pistachio, put it on his lips, and his kid swells up. It is so real. And many kids are peanut or milk intolerance, right? Lactose intolerance, and things will have to be done. But what is that allergy? How does it show you? Well, does it have to be an overall rash? Sometimes it is. That's easy to detect. But what about a little bit of vomiting, a little abdominal pain, a little bit of diarrhea, maybe a diaper rash that they've never had? Those things could be telling you those foods are not what they want, especially when we start introducing them at 6 months, right? That's why we wait every 4 to 7 days. GI dysfunction, we know it causes growth failure. If we don't feed nutrition, the kid's not going to grow, and cognitively, they're going to be behind, right? You got to feed the brain in order for it to get there. Some of the dysfunction is just spit up, regurgitation, nausea, vomiting, diarrhea, and with that goes the abdominal pain, etc. Now, it could be because of dysphagia. Now, there is a diagnosis called DiGeorge. And DiGeorge, one of the things, like a tiny little jaw, and they have a hard time sucking and swallowing. And this is one of those dysphagia conditions just off the top of my head. And we know any kid with a fever, what are they doing? they're burning fluid. So they need that fluid replaced, okay? And it can cause GI problems because not enough fluid. Mentioned it a couple of times now. Let's mention it again. Dehydration. Worst thing you can do to a child to have them severely dehydrated. It's where you see elevated heart rate, decreased blood pressure. That kid's going to look pale, cool extremities, poor capillary refill, decreased urine output. And what causes it? Well, fluid loss in some manner. It could be many things. It could be vomiting, diarrhea, it could be, sweating, or all of a sudden the kidneys are just urinating, and you're getting dehydrated. Um, we know that ketoacidosis, diabetes, and burns all can cause dehydration. These are the things you see. You see the picture of the one on top, this little baby? Do you see the color of that child? It's almost green, it's so pale. The ears, the nose. Look at the fontanelles on both of them. Sunken, sitting there at rest. Next thing I would do, I'm going to listen to their heartbeat then. And because I know the normals of heartbeat for different age children, I'll know if it's too much. And if I'm doing that heart rate, I usually hold their hand because I want to see if it's cool, and I'm looking at perfusion too, right? So these are things we look for. And I think one of the saddest things about a dehydrated infant is they're going to cry. They always do, changing them, assessing them, etc. No tears. Can you imagine a baby crying and there's just no tears coming down? You're like, sunken eyes, sunken fontanelle, colors pale. We know what the problem is, and we know we need to do as quick as we can. Now, treatment. Start an IV, and at the same time, we're going to pull lab works, basic metabolic profile. We want to know glucose. Many of them glucose are way down on the floor. We'll have to replace that quickly. Your potassium, your sodium, your chlorides, your CO2, all of those things are telling you clues into that dehydration. So usually depending vomiting, diarrhea, depending on situation, we know that if you're vomiting profusely and you're vomiting, you're not going to give PO fluids. You're just going to create more vomiting. And they're already dehydrated. Put it in an IV, and we're going to, of course, do our lab works and make sure we bolus the fluids. No potassium, no dextrose on boluses. Adults, children, just don't do it. If you bolus a fluid that has potassium in it, they have not urinated it, you could hurt the kidneys really badly because dehydration can hurt the kidneys. They also say if you don't have a potassium level yet, and if the child voids, it's okay. You can give the potassium in it. And always, like with vomiting, you'll give that antiemetic, that Adonstron, Zofran, IV, according to the weight of the child. All different things to look at for intake and output, urine, stools, vomiting. I've never done sweating. I've never seen a child that profuse before. But if we needed to, put a big diaper underneath and catch it. Know what the diaper weight was before we put it there, and then weigh it when we're done if we think, we're changing it to a fresh one or a clean one. Of course, the big thing is that intake, the output, and that body weight. And fontanelles in children really tell you their status. So the older kid, because of lack of flow to the brain, they might get a little confused and drowsy and don't know where they are. And that could happen. All types of diarrhea can happen in children for whatever reason. So what do we do for treatment of diarrhea? If they are with diarrhea and they're awake and alert, we're going to give them oral rehydration. Pedialyte, Gatorade, Powerade, whatever it is, we need to replace it. They do not need an IV unless they're severe. But usually we say start the liquids. Now, they also will start to say introduce a diet slowly, but things that are easy. It used to be called the brat diet: bananas, rice, applesauce, toast. I still think those 4 things are perfect to start, because if you have diarrhea and you don't put food in there and only liquid, how does that stool become thicker? and tighter, right? There's no food, still going to be water. So feed diarrhea. But of course, be careful with what you feed. Constipation can happen due to many different reasons. One of the things that I've learned is children, because they want attention or due to what's happening in their home, they can hold their stool. I've seen it 10 days with no stool that children come in. And it's scary to think about it. What we do is we'll give them an enema to get it going. But again, finding out with the parents what's going on at home and then just changing a diet. We don't like giving laxatives. We don't like giving enemas on a daily basis, increasing fiber. Raw fruits, raw vegetables is it. We think that can help. Now, a baby is born, and usually the first stool is this gooey, ooey, black-green thing, right? Well, sometimes in the first day, day and a half, they do not stool. Very, very uncommon for an infant. Something is wrong. Is there an atresia, or means there's no opening to the anus, or a stenosis, really bad narrowing, or is it Hirschsprung's? We're going to go in that a little bit later. Or is it the thyroid, a problem with it? So we'll be doing thyroid levels. And is it cystic fibrosis? So sometimes these two conditions, the thyroid and the CF, the cystic fibrosis, can be determined at birth because of no stool. Constipation in the infant. Now, infants, usually breastfed, are stooling with every diaper. It's usually normal. Usually you'll see those infants on formula, which may get constipated. You know, interventions usually are very like homeopathic. Maybe give a little apple juice, maybe get a little prunes. Something like that is better than trying to give enemas or giving laxatives. We don't like to do that, especially in the infants. Sometimes just taking a thermometer and just stimulate the rectum can cause them to stool. So it's something to be looked at, and that's why we measure stools every day in the newborn intensive care and in nurseries. Peptic ulcer disease, kids can have ulcers. You have little warriors. And the treatment would be, you know, usually diet, of course, number one. But number two is something like ranitidine, Zantac. But today they're saying Pepcid, famotidine, not the ranitidine anymore. They say ranitidine now is not the good thing. And a couple of years ago, it was like the best, right? For all of the stomach problems. But now it's the Pepcid.
They took it off the shelves in the pharmacy for a couple years.
Yes, they have. They say that there's some reactions between things. You know, I've heard a couple different things and a couple different meds. Tagamet used to be like ranitidine, right? And Tagamet with Sudafed together was like deadly. You know, and Sudafed, you have a cold, your stomach hurts, you could, and that's what happened. Yes, another one of those. So it was great forever, but now it's gone over to Pepcid. Now, liver problems. So hepatic disorders. You know, you think hepatic, you think more of hepatitis, right? Hepatitis can be due to many different things. Well, what is the liver and what does it do for nutrition? Liver secretes bile. What does bile do? It digests fat. So if the liver, for whatever reason, is not working because it's inflamed, it has hepatitis for whatever type, you know, we're not getting the fat digestion. So what do we need to do to take care of that kid? Well, high protein, high carbohydrates, and get the fat out of the diet. If you don't get the fat out of the diet, they are going to have horrific abdominal gas, distension in the abdomen, and of course, diarrhea will be with that. So we're going to give a good diet, protein, carbohydrates. Okay, here's that Hirschsprung's, which means no stool at birth. for first day, day and a half. Hirschsprung's is also called the congenital aganglionic megacolon. What do those big words mean? Well, it means at birth, the colon, the descending colon, has no nerves in it. Well, what does that mean? Well, no nerves, no peristalsis. No nerves means it can stretch out this big and the baby won't feel it. And we know the baby is still going to have gastric juices and normal juices and saliva, and they're swallowing. So stuff is going down and it gets stuck in that lower colon right there. Now, it is a bowel obstruction, absolutely. So, how do we diagnose it? Well, 24 to 36 hours, no stool. Sometimes, if you look at the rectum, that little tiny little piece, a little bit of stool could come out. It's like taking a little pastry thing with frosting and squirting it on a cake and make designs. It's like a little ribbon. It's the only thing that will come out. So, Hirschsprung's is ribbon-like stools, maybe. Now, what is the treatment of this? Well, this is aganglionic, which means no nerves, which means it's not useful. We don't want it there. It can only create problems. So we're going to remove that piece of colon. Initially, they will get a colostomy. Usually before 1 year, they will close it back up. They do a biopsy, a barium enema, they do x-rays, all of that stuff to confirm it. But these parents need to know they will be an ostomy, but they can close it up. And of course, before potty training is always what we see. Acute appendicitis. You know, McBurney's point, right lower quadrant. It's that little thing between the small intestines and the large intestines. And our goal is to be able to diagnose it with an ultrasound. These children, you can see them walking into their rooms. They're, that middle age, 5 to 10-ish. You see most of them. They're bent over, holding their right lower quadrant, limping on the right leg, and you could see they hurt. And you're like, oh, that's an appendix. So immediately we put them NPO, get them in the room, get them to ultrasound, and look at it. Well, and then it ruptures, which means the pain stops. If the pain stops on an appendix while you're trying to get them up to surgery, that means that their peritonitis is already ruptured. How are you going to treat the normal appendicitis post-op? They usually go home the same day. It's done in the morning, they're home in the evening. They send them home laparoscopic. It's pretty easy. If it's appendicitis, now these children have these appendix that's burst and spewed all of this toxic, liquid into the peritoneal cavity, and the intestines are angry because it hurts and it just keeps bothering them. Okay, so you have a horrible infection. Now you can't eat. These intestines are angry. So IV fluids, antibiotics, absolutely. You always will monitor lab values. Just look at the white count go from 20 down to 10 as we're starting to cure it. These children hurt. Make sure they have their pain control. They have to get up out of bed. They have to ambulate. All the post-op care these children must do. They have in an NG tube. And why do we put an NG tube in these children? Well, I told you the intestines are very angry. And you already have a little bit of liquid, the gastric juices, whatnot, want to go down there. And the intestines can't tolerate anything. So we put an NG tube in there to keep out all of these secretions, to give those intestines a chance to be able to heal. The other thing we watch closely is their wound. Now, this is ruptured. The whole inside of the peritoneum is now infected, and now you've closed two infected pieces next to each other. It may not take, which means this could be a dehisce, which means the wound could open up. So always check the wound, make sure that it's, the suture line is good. Again, pain control, up out of bed, cough, deep breathe. Don't forget the pain medicine on these kids. Now, intussusception, something that you don't hear in adults. These are usually those 3 months to 3 years. The youngest I've ever seen is 5 months, which is rare. Usually it is that 2 to 3-year-old age, believe me, that I've seen. These kids come into the ER, usually a parent's holding them, and their legs are going back and forth, and they're crying, and you can't console these kids. It hurts because the intestines had sucked up into each other. That's a telescope. That's what it does. And then the nerves, and it swells and it can't get out, and it really creates pain. When it gets sucked in there, sometimes you might see currant jelly with streaks of blood in a diaper. So one of the things I would check for is when I see the parent holding this child, I touch the belly, it's tense. Then I try to peek underneath the diaper and see if I see any of these things, a currant jelly type of stoolish in there. These kids go to their ultrasound many times before you get them to ultrasound. It comes apart and the kid's happy, and don't send them to ultrasound because it's not like this anymore. It came apart. Many times these kids are sent home, increase the fiber in their diet. If it stays there and we can't get it out, we get the ultrasound. Many times these kids, we will do, they say barium enema. I've seen air enemas where the radiologist puts a tube up the anus and pumps air under fluoroscopy and watches it pop. If it does not come out, and then when it pops, of course, high fiber diet, watch closely at home. Sometimes, depending, they might be admitted, but usually they're sent back home. If that don't work, then they'll send to surgery and they'll do a colectomy, take out a piece of intestines and reconnect. And I've only seen that once. Most of the time, it just resolved by itself. All of a sudden, the kid was great. And I've seen many air enemas. Now, diverticulum, small intestines. It is a malformation. They say it's a fetal mesenteric duct. What is that? Well, I call it this little outpatching of tissue that goes into the small intestines. But that little outpatch has a big blood vessel in it. And sometimes with normal wear and tear, it rips and blood starts dripping through the small intestines. It's the distal port of the small intestines, and it drips. And you'll see what we might call painless rectal bleeding. And that sometimes is what brings them in. They do all sorts of things, to look at it, the radionuclide, whatever. They do the surgery, they take that little duct out, and they do really well. Not a problem, but it does require surgery. IBS, mouth to anus, ulcerative colitis, and segments, Crohn's, right? This is, many, many children and adults do suffer from this, caused by usually stress. It's caused by diet, and it's something that could be treated medically, or sometimes pieces have to be removed surgically. The big thing is nutritional support. And then usually, like in the Crohn's side, giving steroids to try to stop that inflammation. You see, sometimes many of them might go on some of biologics, like a Remicade or even Humira. Some of them are put on to try to stop the body from having the intestine so fragile and inflamed. If these things are done, they keep following up, they should do okay. But it does take a lot of work to get there. Now, small short bowel syndrome, SBS. This happens when a piece of intestines has to be removed due to whatever. So Jessica was a triplet. Jessica was a cardiac child. She had a very severe hypoplastic left heart, requiring 3 stages of surgery, one at birth, and then one at 8 months, she had it done, and then later on. Well, the eighth month one, she came in and had her surgery and really had a horrible post-op. She was on major ventilation, very sick. And we were feeding, it was said we give little small 1, 2 mLs an hour feed. It keeps the intestines moving, blah, blah, blah. Well, it ended up causing necrotizing enterocolitis, maybe due to a hypoxic episode, whenever it was. And this child's abdomen got distended, and we saw something was wrong. So that they did the workup, found it, they went to surgery. They removed 48 centimeters of her small intestines. I think about 20 centimeters were left in her little body. What does the small intestines do? It absorbs all your nutrients. So short bowel syndrome, that's what that means. How did they take care of her? How did they give her nutrition? I met her at 18 years old. The last day I worked at Nicholas, I saw Jessica. She came in with her mom and the triplets. Yes, she was skinny. She wasn't cognitively as the other two, but she knew exactly who I was, and I got a big hug from her because she knew I took care of her as that, young child. So, I mean, she had a G tube for feeds, a Broviac for hyperaldosteronism lipids at night. And if she wanted something by mouth, she could have it. But they kept the nutrition up. So they gave her the best nutrition they could. So gastroschisis is something else that can happen. And this is when the midline doesn't close and the stomach stays out. And they actually are born that way. Our concern is always infection, maintaining integrity of the tissue, and then they put it up what we call a TP. And slowly every day the surgeon moves it, pushes it down slowly, slowly, and then they can close it. I mean, it's all connected the way it should, but it was born on the outside. Hernias. Anybody ever seen a little umbilical hernia that's popped out like that? You don't want to push it in and out. It's squishy, squishy, whooshy, right? And that's what it should feel like. If it gets hard, red, painful, that is when it's either incarcerated or strangulated, whatever the name, and that requires surgery. It can twist in there. I mean, they're benign? Yes, but because it sticks out, they have a chance to twist. So usually they tell you to fix them. One of the hardest children to treat as a newborn is a diaphragmatic hernia. The diaphragm, the left side doesn't get there. It's not. And the intestines go up into the chest, so the left lung doesn't form and it pushes over on the right lung. So can you imagine ventilating this and oxygenating this child? Very, 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 very difficult. Usually they end up on a heart-lung type machine called ECMO. But these children, eventually, when we get them stable, we pull it down and we'll put a mesh there. But these children are very sick. But that's the most severe of all hernias. You have malrotation in volvus. Malrotation is just the intestines go around an artery and twist. Volvus, it goes around and twists in the intestines itself. And when fluid stuff can't get through the intestines, it bursts, peritonitis, very similar to your appendicitis here. Anorectal malformations. Were you taught in maternity the one thing you do is a rectal temperature on all newborns, right? You know why? Not for their temperature, to make sure they have an anus. Because if they don't have an anus, where's everything going? Right? It just blows up. It is actually an emergency. They need to put a colostomy on that child. Be able to drain the fluid, just the normal juices that they have in their stomach and their mouth, etc. Usually, later on, they're going to try to recreate an anus of some sort, but it is a multi-surgery that they have to do for it. Another thing is nurses, and I've found these where their physician don't because we spend more time with the babies than they do. I mean, it's a reality. We know that. Nurses are there 12 hours a day, right? We're looking at things. We might see stool coming out of a vagina or out of the urine or urine out of the anus. These are fistulas, and again, they need to be repaired. Now, vomiting. Vomiting is either a dribble or it's across the room. And the one thing I want to know every time I see, especially young children, babies, what does it look like when they vomit? Is it a dribble or across the room? Because treatment is different for both. It could be the older kids, they're nauseous. It could be bilious, that greenish stuff in it or not. What do we do with vomiting? Well, we always worry about dehydration, right? If a child who's actively vomiting is dehydration, this is the one that gets the IV. Absolutely, that metabolic profile. I want to know where those electrolytes are, what I'm starting with. And again, no potassium, no dextrose in those IVs when you're giving boluses. And you're not going to feed a child who's vomiting until we give it a dextron, we give it time to work, give the bolus, make them feel better, and then they can start with small sips of Pedialyte working into their diet. Children get into everything, don't they? They like, how do they explore the world? I've said that one of the first days that I met y'all. Everything in the mouth. They want to taste it, they want to know it, they explore, they comfort themselves. I mean, they will put anything. Now, most common thing I've seen is Flintstone vitamins, the chewables. They love them because they taste good. Now, if it's acetaminophen, Tylenol, you got troubles if they ate a bottle of that because we know that is toxic to the liver, and we don't. That's going to be your sick child. I've seen rat poison. I've seen mamas, grandmas, cardiac meds. Depends on what it is, depends on the treatment. The first thing we do is call poison control. When they come into triage, you do your assessment, get your history, your vital sign, calls poison control. They're going to tell you the newest, latest, up-to-date treatment for it. We write it down, send them into the ER, and then they watch them for whatever time that they want them to be watched. If they need to have charcoal, we give them charcoal. And we tried to disguise that charcoal so they don't know they're really getting it. Put it in opaque glasses and put it in with apple juice or juices or Pedialyte, not Pedialyte, Gatorade or Powerade that sort of tastes good. And try to get it in them. Now, one other thing that happens, not so much here in Miami, because we're not really that old in comparison, but there are some cities, older homes, where they've used lead paints. Windowsills are great, but they're up at the level of the kid's mouth. And they're looking out the windows, and what are kids doing? Oh, they're biting on those windowsills, right? If it has lead, they're getting lead poisoning. And lead poisoning can cause seizures and death. So I have to be careful knowing your home if it has it, or you see signs and symptoms for them also to get, lead levels, see where it's at. And if they do have high lead levels, there is chelation therapy orally, or there is that apheresis with a machine. Now, reflux. This is the infant, the child that comes in that dribbles after every feed, dribbles. They've been taught how to burp, how to not overfeed, sit them up afterwards. We've done all the things to try to help them. We've told them to put rice cereal into their formula or into the breast milk to try to hold it down there, but a lot of times they still dribble. Now, reflux is the milk goes into the esophagus and it hurts. You'll see infants arch their back like, oop, this kid is refluxing. You can tell. The problem is those aspirations into their lungs. That's your biggest concern. Now, older children, It is going up in their lungs. And they're going to complain of that heartburn, that chest burn, and they're going to be coughing because it's mini aspirating. So if those are your signs and symptoms. Now, we have medical treatment. We know it's going to be your Pepcid and for all of the different GI meds in pediatric doses. Everything adult children can take, but in children doses, milligrams, micrograms per kilogram. One of the things, and this is the most drastic of all, if a kid continues chronically with pneumonias, aspiration pneumonias, and the kid needs something, or it's getting to be too much type thing, they'll do something called a Nissan fundal plication. Any child adult that has a G tube, it's usually a gastrostomy tube with a fundal plication. Why do they do that fundal plication? Well, G tubes, we just drop the fluid in there and walk away, right? And we don't worry about vomiting. Why? They take and do that Nissan fundal plication. They bend over the top of the stomach and stitch it on the esophagus, and it prevents vomiting. If you see a child, an adult, vomiting with a Nissan fundal plication, there's a problem because they shouldn't. And that can help that esophagus to heal. So, hypertrophic pyloric stenosis. Well, we talk about GERD, we talk about dribbling, right? This is take this infant 3 weeks to about 3 months. Some of the literature says 6 months, but I've never seen it that old. 3 months, 7, 8 weeks is that sweet spot where you see it a lot. These children, this infant, hold them up when they vomit, point him to a garbage can across the room, and they'll hit it. 2 points. I'm telling you, it is forceful. It is, watch out. If it hits the floor, it's going to splat all over your feet. What happens? They eat, they're happy, they're normal kids, they're eat. And that little valve, the pyloric valve, which empties into the duodenum, is stenotic. It's hypertrophic. It's muscular. Nothing hardly is getting through. So the kid eats, and he's fine, smiling, and all of a sudden, in your face. It is like a lot. So if I hear this is forceful vomiting, my hand is going to go up under, because usually mommy's holding their baby because they're possessive, which is great. There's no problem. Put my hand up and I feel underneath their xiphoid process. I'm going to feel an olive or a marble size little something mid to right side. That is actually the pyloric valve is hypertrophic. I'm like, that's what it is. So immediately, do not give your baby anything more to eat or drink. We get them to ultrasound, we diagnose it, we start an IV, and we send them up to the OR. They do a pylorotomy, which means cut open the muscle, open it, and let it flow. And they wake up and they start with, if it's breast milk, when they want to eat, they start to say, start breast milk, but small amounts more frequently. Formula, usually like half strength, or start with Pedialyte first. And usually they're home in 2 days. And usually they do well with no forward outcome problems. Left lip, we're talking GI, it starts with the mouth, right? Children are born and their mouths, their lips aren't closed, their palates aren't closed. And there's twofold problem. Number one, you got a parent looking at their child going, because it's all open and it doesn't look that nice. It's not that pretty baby. So as a nurse, I'd say, oh my God, look at the hair on that child. Or, oh my God, his baby's eyes are so big. Wrap them up, give them to the baby, let them know there's other things to look at instead of the defect. Oh, he's holding your hand already. Yeah, it's a reflex. Yeah, it's all right. It's a reflex grasp. I'm not telling him that. The bonding is hard. It really is sometimes. The baby, second problem. What does a baby comfort themselves with? Sucking, right? They can't suck with a cleft lip because there's no suck and the pacifier falls out. So that is a problem. So what do? Well, at 2 to 3 months, we will do the surgery. We put that Logan bar there, so when they smush their face in the bed, it's not going to rip open. They do really good plastic closures. These are all the types. This is in your book again of cleft lips. Now, at times, it's not just the lip, it's through the palate too. And when they drink, it can go up out their nose because there's nothing to cover it there. So they've got a lip that was closed at 2 to 3 months, but the palate, they wait about 6 to 12 months. If we wait later than that, they can't pronunciate correctly. So it's all about language. So we need to get that palate done before 1 year. Infants, how are you going to feed them now? Well, if you want to breastfeed, you're going to have to be squeezing your breast as they are just clumping because they're not sucking. You're squeezing it in their mouth. So to breastfeed might be a lot of work. There are some parents who will do it. Or these bottles here are called Haberman bottles. It was developed by a mother of a child who had cleft lip. And the upper part is very soft. And when you turn the bottle over, you're feeding it, but you're with your fingers slowly squeezing it. Then you put a little, and there you can see them. They're getting satisfied. They feel like they're sucking and swallowing. So making sure they get enough food, enough nutrition is the big thing with cleft lip. Now, one of the things that will make you immediately make your child nothing to eat, nothing in the mouth is esophageal atresia or tracheoesophageal fistula. Well, the esophageal atresia means the esophagus does not connect to the stomach. Now, the stomach is there, but there's no connection. Sometimes with it or sometimes separately, you have your esophagus and your trachea, and there's a connection between the esophagus and the trachea below. So guess what happens? They swallow right in through that fistula into the lungs, and now you're aspirating. These kids are gagging and choking at birth because they do have mucus, right? They do try to swallow. So they're mini aspirating already with their own mucus. So our goal is try to keep that airway as clean as possible. You prevent infection. So immediately, NPO, IV fluids to give them their nutrition and antibiotics for infection prevention, right? That's like a prophylactic sort of thing. Sometimes they do immediate surgery and connect or disconnect or whatever they need to do. I had one girl, but she was cardiac. She had to wait till she was 8 months old to be fixed. So they put a gastrostomy tube in for the meantime. But usually they'll fix it pretty quick. And these kids are healthy, normal children. It's just that there was wrong connections. So a lot of different things today, don't you think? Diane, where'd you go? I saw you earlier. Thank you, my dear. Please keep on camera, even though I can't see you all the time. So what do you think about GI? Do a lot of different things that you've never saw before?
Yeah, very new.
Okay, so who wants to win cahoots tonight? Kevington, you're due. You think so? All right, well, let's go ahead and let's try. I know Miguel is that one who wants to. We know Anna Beatrice, aka Betty, she's going to try too. So let's go for it. Oh, hello, Dr. Brown. How are you tonight? Anything you want to say?
I'm keeping my eyes on you, girl.
She's always here looking after me. Can you imagine? That's okay. I do not mind it. Oh, you're welcome. You can join our cahoots. All you have to do is point your phone, take a picture, and there it is. Push that link and you get there. So here we
But then I'll
go.
forget what I'm writing about you.
Oh, no, not again. Here we go. All right, GIGU again. If you have your sheets that I gave you, those little things, try as we're going along, to see what is the diagnosis compared. There are some key things like currant jelly stools and ribbons and olive shaped, deformities in the abdomen. These are things that they like to test on. And these are things that you're going to be looking for if you ever work pediatrics. There we go. All right, here we go. Let's start it. Unbelievable. We're at week 8. Next week starts our reviews again for week 10, exam 3. A multi. Start it with that. All of the following are symptoms of dehydration in an infant. Remember again, dehydration is so dangerous for children. It's one of those things that you don't get perfusion, you could kill kidneys and you could kill, this cognitive delays in these children. Dehydration, we need to be aware of. So, what do we see? Well, we did them all. Now you'll see a decreased urine output. Remember, dehydration, not enough fluid. What do you see? Elevated heart rate, decreased blood pressure. You'll see that dry, pale skin, those dry mucous membranes. You'll see that tenting, of loss of elasticity, weak, confuse the older kids. So all of these things, adult children, you're going to see it. Dehydration, it's how you do the assessment and you make your nursing diagnosis. So what is priority treatment for a child with dehydration due to profuse vomiting? So your kid is vomiting. Priority, what do you do for them? Remember, we don't like dehydration in children. Adults tolerate it better. So if they're profuse vomiting, if we gave them more fluid, guess what happens? They're going to vomit more. So we're going to rest that tummy, give IV fluids and an antiemetic. I mean, usually putting in an IV, we're going to take that electrolyte, remember? And we'll give that antiemetic, a Dunstron, that Zofran. What is the treatment for an infant with diarrhea lasting for 4 days? So if an infant is having diarrhea, it depends on 2 things, but usually with diarrhea, we need to give the oral and we need to start giving them something to eat. If you don't give them food, the diarrhea is going to continue and it's going to be liquidy. So we start with small amounts of Pedialyte after the history, and if the child, of course, is awake and alert. IV fluids are only severe type of dehydration, and the kid's not able to take PO, but oral rehydration is usually the way to go. What acid-base imbalance may you see with a child that's having profuse diarrhea? Now, many of the things that we're going to see is, I know Hesse NCLEX loves acid-base questions. You need to know what causes what and what you're left with, okay? So if you're having diarrhea, what are you losing? All of those digestive enzymes are alkaline. You're losing alkaline like crazy. So what is left? Metabolic acidosis, okay? Conversely, if you're vomiting like crazy, it's gastric acid, right? You're losing acid. What are you left with? Metabolic alkalosis. And I hope this helps you also in your med surg, thinking of it that way. If an infant is not past meconium stool within the first 24 to 36 hours, what would you assess for? That was one of the slides that I gave you. You know, sometimes this is the only way they find these things out because there's no inkling or no history about it. And all of a sudden they're not stooling. So what do you be checking for? Well, hypothyroidism. That's important because children need thyroid hormone or cognitively they're going to be delayed. They have to have it. So this might be the way or only way that they knew about it. Hirschsprung's disease, that's that big aganglionic megacolon, and it doesn't get the stool out there, except for maybe ribbons, right? And of course, cystic fibrosis. Now, sometimes they have the history, sometimes they don't. Deficiency of vitamin D causes what? Well, what is vitamin D used for? This is one of those nutritional questions, part of the GI. Vitamin D helps with bones and it helps with calcium. You don't have enough, you have rickets, these funky bones that are crooked and tend to be more brittle, rickets. Scurvy is vitamin C. That's when they used to take oranges on the ships back, in the 1800s. They made sure that they had oranges, right? To prevent vitamin C. Jaundice has nothing to do with vitamin D. Again, vitamin D is bones, okay? Can cause osteodystrophy, bones not being formed at the way that they should. A multi. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? So think about it. We know we have to replace fluids. They're unable to eat or drink. They're vomiting and diarrhea. What is the best way to treat that child? And we know, number one, IV fluids. They're profuse vomiting. They can't eat. You're not giving them PO. The last thing that you would give that child would be water. You're going to give them Pedialyte, Gatorade, Powerade, okay? And always priority is to get that basic chem profile. I want to know my electrolytes as I'm starting the treatment on this child. A multi. What nursing management would you anticipate for a child with a ruptured appendix postoperatively? Remember, this has spewed all of that material into the peritoneum, and peritoneum is not happy. What is our biggest concern here? It's peritonitis. How do you treat peritonitis? Well, you're not going to have them on complete bed rest. Post-op, any abdominal surgery, would you have them in bed? No. Adult or child. You want them up out of bed because you're worried about clots, DVTs. You're worried about pulmonary embolus and pulmonary problems. Same thing with kids. There's no difference there. So there'll be NPO, IVs, IV antibiotics, and that NG tube is to take any fluid out of the stomach so it's not bothering the intestines. Remember, those intestines are angry. All that stuff is touching them. It's caustic and it hurts and they don't like it. And then, of course, it was a very dirty inside. They call it unclean or infected. When we reconnect it and put an incision line, Sometimes it doesn't heal properly and it dehisces. So always assess that surgical site. Passage of urine, usually at night, in children who could have voluntary bladder control. Now it is called enuresis, but because I can't put everything into a PowerPoint, there are two conditions here I'm going to mention. So listen. Epispadias, hypospadias are the male. Epispadias is when the urethra does not come out the tip of the penis. It's anywhere on the top at birth. Hypospadias is underneath, anywhere. It doesn't come out the end. And before they're potty trained, what they do is cut the penis down and flay it out, and they create a lumen. They put in a catheter, close it back up, and they need that foreskin. This child cannot be circumcised. So the Jewish faith might have an issue with that, right? And they then will leave that catheter in there for 7-10 days. Urologists will remove it later. What do we do with that? Put it inside a diaper so you don't get urine everywhere. That's it. Leave it alone. Okay? So I've seen one of them. They do very well. And just keep that catheter inside. That's it. Or we'll get urine everywhere. Multi. What's Hirschsprung's? Hirschsprung's disease. Remember Hirschsprung's, there's no nerve, so it's a congenital absence of the parasympathetic ganglion cells, which means no nerve cells. And we know it's a megacolon or it's a bowel obstruction. Those are things we call it. We don't call it the other. Ileus is when your intestines stop working after surgery, okay? That is not this one. Multi. When teaching parents about Hirschsprung's disease, the nurse would include what? How are we going to treat it? What are we going to do? We think it's Hirschsprung's. I mean, newborn parents, they want to know everything that's going on with their infant. And remember, the mothers are hormonal as heck, right? So they're very emotional. So they need to understand what's happening. Well, Hirschsprung's is basically a piece of bowel that has no nerves. It's got blood supplied, so it's alive, but it don't work. It causes that bowel obstruction because peristalsis doesn't work. We know if they're older, because sometimes they go home with it, we don't catch it at first because maybe, enough is coming through that we're not seeing it. So if we find it, monitor those infants' bowel habits afterwards of the surgery, always. And then what they do is they do a colostomy and close it up within a year. We do not like treating children with any bowel, like constipation, with laxatives and enemas. It's only in an emergent care, okay? We'll tell them to increase the diet, with fiber, increase liquids. Miralax is probably the biggest type of laxative we might use in some children, but that's not even all of them. That's very few of them. What type of stools would an infant with Hirschsprung's disease have? Remember, it's that big megacolon that goes through the tiny little opening to the anus. So what would they look like? Remember, it's like a frosting. We're putting frosting, on the cake. It's ribbon shaped. Absolutely. Which is a condition that occurs mainly in children when the intestines telescope into itself? Remember, these are your young children, and it comes in and those nerves, and it hurts. And I'm telling you, these kids are crying. They're like, I don't know what to do with him. He hurts so bad. And you see those legs, you know exactly. And it's called an intussusception. Current jelly stools, remember? I'm going to touch that abdomen and I'm going to check a diaper. Current jelly stools is that one. Gastroesophageal reflux disease. What is that? So gastro or GERD is the food goes up into the stomach and it burns. And remember, it causes a lot of problems with aspiration pneumonia. Older kids will cough with it. IBS involves what? IBS is anywhere, mouth to anus, right? It's everywhere. It's Crohn's that are the segments. Very good. What would the nurse be looking for when a patient has a mecal diverticulum? Remember, that's the distal portion of the small bowels. And some sort of fetal duct thing is left there, and it's this little tab that's there, and it gets ripped. And it's got a big blood vessel in there, and what do you see? It's called painless rectal bleeding. Do we see abdominal distension? No. Usually maybe some little tenderness, but it's usually the bleeding that brings the parent in with that one. A 6-year-old goes to the ER due to abdominal pain, fever, and vomiting for the last day. What assessment's priority? What do you need to know about first? How do you take care of this child? What is going on, right? You need to figure it out. As a triage nurse, and I did a lot of triage, I needed to know where to place that child so they got the best care. Is it urgent or is it less urgent care? And that's the description of the abdominal pain. Is it an appendix or is it umbilical or maybe epigastric? All of these things it could be, okay? So description, very important. What would the nurse expect to see in an infant with biliary atresia? Atresia means there's no opening between the liver and the common bile duct. No bile is getting down into the small intestines. What would you see? Well, they're going to be jaundiced like that little girl, for sure. But it's not going to color the urine. And again, bile does what? It digests fat. So abdominal distension, okay? Pretty good. You did good with that one. What structure of the mouth can be impacted by cleft lip and palate? And it's everything. It's a soft palate, hard palate, lip, all of them. Remember, the first one we do first is the lip, then we do the hard palate after. And we worry about speech. That's the big thing. So cleft lip palate repair is done when? The lip. Remember, we need to get them to be able to put their mouth and their lip around that bottle. This is, part of their growth and development. We need, that sucking. We do it between 2 to 3 months. So when do we do the cleft palate? That picture really shows a very good surgical closure, and you see the approximation of the lip lines. They really pay attention to that today. That's about 6 to 12 months. I had a child with Pierre Robin. He's not there anymore. He was over at Patches when he was born, because he is alert-oriented fine. He had to go there because of the palate and the lip that he had. But that palate was so open. His lip was fine, but feeding him as an infant, it was like you had to hold him right up. You had to feed him slowly, and it would come out his nose. And students couldn't feed him, but of course, here, Betty, you feed him, of course. And I would take it over for them because I, of course, have experience with it. But he was very tricky, very, very tricky, because there's no thing that holds it from coming out the nose. Esophageal atresia. What is that? A is absent. Remember that. Osis is narrowing. Those two things do not forget. So atresia is no opening into the stomach. Remember those words. Atresia. A is without. Osis is a narrowing. So what are the classic signs of esophageal atresia and tracheoesophageal fistula? You get a newborn. What could it be? So remember, if it goes down the esophagus, it's going to come back up. There's no ending. If it goes down the esophagus, it could go into the trachea, into the lungs. I'm going to be coughing and spitting and sputtering and turning blue. I'm having aspiration pneumonias. Okay? Think about it logically. All right? And you can answer that one. What is it? What could happen? Because normally we take when we swallow, the epiglottis covers the trachea, right? Yeah, it still happens, but when it goes down the esophagus, poof, there's another opening right into the lungs. And remember, from bigger resistance to least, that's where it goes, right into the lungs. A multi. Neonate with suspected tracheoesophageal fistula nursing care should include what? So tracheoesophageal fistula, our biggest concern is about mini aspirations. So elevate the head of the bed. Nothing by mouth. You're gonna have suction at bedside, right? And our biggest concern is we can't eat, so give them IV fluids, and we're worried about those aspirations. It's antibiotics, okay? These kids will not be fed. You want to feed them? Right down the esophagus, right into the lungs. A 5-year-old child's complaining of epigastric pain and a persistent cough. What is that? You got pain right there in the chest. It hurts, it burns. What is it? And that's reflux. That's the GERD. Very good. What is ranitidine used for in a child with peptic ulcer disease? I still use the name of that drug only because it's included into your textbooks. but we know, thank you, Huffington, it is Pepsid now. The famotidine, we don't use it anymore. It was taken off the shelves. What does these drugs do? It reduces the acid. It doesn't neutralize anything. If you gave them a Tums, that would neutralize it. But Pepsid, ranitidine, it just stops it from being produced, okay? That's the difference there. Signs and symptoms of hypertrophic pyloric stenosis. Stenosis is a narrowing. A narrowing of what? The pyloric sphincter. Where is it? What does it cause? So what you're going to see is a child with projectile vomiting. And if you go and you feel right underneath the xiphoid process, a little bit to the right, you're going to feel this little olive, or I call it a marble, same thing. And you're going to say, oh, that's the pyloric valve. It's hypertrophic. You will feel that. Absolutely, you do. Signs and symptoms of a hypertrophic pyloric stenosis is what? Remember my question for any infant coming in who's vomiting. I want to know what? It's projectile vomiting. It's not poor appetite. These kids eat. They're hungry, hungry, hungry. But it goes down there, stays there a little bit, and then poof, it's gone. And then they're hungry again and they're crying to be fed. So it's actually still a good appetite. Preoperative treatment for a pyloric stenosis includes, so the kid is vomiting because it can't go down. They're getting ready to go to OR so they can open up that pyloric sphincter and do a pylorotomy. It makes it open, stretch it out. So we need to start IV fluids. And again, nothing to eat because they'll just vomit again. What does the celiac disease affect? Where is it? We know it does with absorption. We know it has to do with gluten, wheat, rye, barley, and oats. But where is it? What are we worried about? Remember, it's all about nutrition. So it's small intestines. Remember, small intestines does a lot of most of the absorption of all the nutrients that we're eating. If you have celiac disease, what should you eliminate from the diet? You tell most kids they can't have macaroni and cheese and chicken nuggets. They're going to be really upset, aren't they? Because it's full of all these breads, wheat, rye, barley, and oats. Remember, all of those things they can't have. They can have vegetables, dairy, they can have chocolate. A multi. Vitamins that children with celiac disease are prone to lose are. Remember about the abdominal distension. Remember, they cannot absorb fat. That's why their stools stink and they're malodorous. It's just, and very pale looking things because fat is not absorbed. So, fat soluble vitamins you're concerned about. Vitamin C is water soluble. The rest are all fat, okay? Remember that. Vitamin C is water soluble, not fat soluble. What foods would you select for a child with celiac disease? So wheat, rye, barley, oats, they can't have. Rice is a great alternative. And don't they have potato flour too? I mean, there's all different sort of flours today. We're so lucky. So they can have dairy, they can have fruits and vegetables, so and they can have eggs, so bacon, omelet, banana, milk, perfect. When we look at the yellow one that some chose, fish sticks are covered with bread, macaroni and cheese are macaroni made from wheat, rye, barley, or oats, okay? Apple juice is okay. Phimosis. I mentioned this with my grandson. So phimosis is when it's so tight you can't withdraw the foreskin. Now, this is really the only time today where they say do circumcision. They used to do them on all the males. It was part of routine. All right, you want them circumcised, fine. But today they're not doing them as much because they say, well, if it's there, maybe there's a need for it. So there's a lot of ambivalence there. But if it's too tight and you can't pull it down, and it's me who can't pull it down, it needs to be removed. And that's why we did Christian. What is a hydrocele? Another new thing, hydrocele. What do you think that means? This wasn't on a PowerPoint, I'm just mentioning it. I mean, sometimes you see incontinence, sometimes you're going to see a pain called testicular pain. Treatment, they usually give a shot of Rocephin. So, I mean, this can happen in children or adults, and it's pain. It's in the testicle, so it's testicular pain, and usually there's incontinence that goes along with it. So it is collection of fluid, and it hurts. They don't like it, and the infection cures with Rocephin. What is cryptorchidism? This is another term that's not in the PowerPoint. This is why when you go to the pediatrician on your first visit with your boy, he does an examination and he feels both testicles, right? Are they there? And if they're not, it's cryptorchidism, okay? It's not a hypodysplasia, no hypoplasia. It doesn't come down. Now, the one thing is remember males, cold and hot, they'll suck in and pull out. So we have to make sure, are they really there or not, right? So if you suspect an infant with cryptorchidism, how would you examine this infant? If the testicle is stuck up into the abdominal cavity, it's too hot and it will die. So they're going to have to do surgery and pull it back down. And that's why this is important. So males, when it's cold, testicles get sucked up. When it's in a warm room and they're warm, they tend to hang more. So if you are looking at an infant to see if both testicles are there, you're more apt to see it if it's warm because the testicles will hang better. And then you're not going to make a wrong diagnosis. A hypospadias is. This is from one of the other questions, and I told you what it was. And a hint you need to know, is it ventral or dorsal? Is it on the top or the bottom? The urethra don't come out the way it should. It's not on the end. It's underneath, and it's called ventral. Very good. A multiselect. How is the hypospadias corrected? Now remember, we like to do it before they're potty trained. We want the urine to come out the end, so it looks just like daddy's, right? And remember, they fillet that penis open, cut it, open it, and make a cavity, put a catheter in, and then close it up. So we use the foreskin, there is a stent that is there when we were done. And this is general anesthesia. Their penis is cut open. Can you imagine if it was under local? No, they're not putting all that lidocaine in the penis. They are putting this child to sleep. What is bladder exstrophy? It's like a gastroschisis, but of a bladder. I've seen gastroschisis multiple times. I've seen bladder exstrophy once. And remember, just because it was born on the outside doesn't mean they're not all attached the way that they should. Our goal, whenever we have any body part born on the outside, like the stomach or the bladder, is make sure we keep the infection down, we maintain the integrity of that tissue, okay? So it's that midline didn't close, it's embryonic, and the bladder's up and open. And yes, a couple days after, within a week, they stuff it back in there. Slowly, they push it back in. So what is the priority nursing care for an infant with bladder exstrophy or a gastroschisis, the stomach born on the outside? So again, it's all about tissue integrity. The bladder is the GU system. Why do you want to monitor the bowel function? You're going to monitor the urinary function, right? Now, remember, the bladder is still working the way it should. It just means that you still monitor the output the same, but we're worried about it because it should be inside that belly. It shouldn't be on the out. So we're going to worry about the tissue integrity. What are the clinical manifestations of nephrotic syndrome? Remember, this is not renal failure. What does the kidney say when they have nephrotic syndrome? They say, protein, yuck, I don't like you, let's get rid of you, right? It's the easy way to remember. So their albumin is going to be low. They're going to have peripheral edema, and just their blood levels, albumin, the protein, it's going to be gone. So again, nephrotic syndrome, the kidneys still work, they just don't like protein. So children with nephrotic syndrome are often given what medications for fluid overload? Remember, they're swollen, extracellular. They have no protein intravascularly. If they reintroduce that protein and then hit it when they're done with a diuretic, they can suck out that edema and flush it out and increase the urine output. And it's albumin and Lasix. Do you understand that concept? That is a huge concept. Replace the protein. It's going to create that isotonic, hypertonic, suck out the fluid, and then that furosemide Lasix is going to get rid of it. And how are we going to monitor these children? Intake, output, daily weights. Are they losing fluids? What is used to treat nephrotic syndrome in children? When they're in an acute crisis, it's exactly this. The kid comes in and they're all swollen. We know they have nephrotic syndrome. We are going to give them steroids, and steroids are the treatment. Again, with the daily limiting fluids, watching the salt, be careful with infections, monitoring intake, output, daily weights. A child is admitted with acute glomerulonephritis. What recent illness could validate this finding? Do you know what the lab value that they may draw to take and look and see if acute glomerulonephritis was caused by that? Well, we know that acute glomerulonephritis, the acute stage, is due to a strep infection. There's something called an ASO titer, an anti-streptolysin titer, okay? And that measures strep in the body. And if it's positive, we know the strep is there, that caused it. And then we know, treat it, antibiotics, we know how to treat it, okay? What is the priority nursing care of a child with nephrotic syndrome? Remember, nephrotic syndrome's all about fluid balance. Kidneys, what do you worry about? Fluid balance. So, monitor daily weights. Good job. Why is erythropoietin used in chronic kidney failure? Renal failure. Remember, erythropoietin is normal in the body and it helps, but in kidney failure, it's gone. It doesn't work well. So we can give, our own, and it's used there to produce red blood cells. Children, adults, and kidney failure, their hemoglobin hematocrits are really low. It's because of the erythropoietin. And now we have the synthetic erythropoietin we give subcutaneously, and that can help the body produce its own cells instead of always having transfusions. It can decrease the quantity of them. A multi. Children with chronic kidney disease can have renal osteodystrophy. What can this do to a child? It has to do with vitamin D. Osteo means what? Bone. Dystrophy means not normal. So what would you see? Read the question, see what it says. And it is skeletal abnormalities, growth retardation, but remember, it also affects calcium. What does the parathyroid do? Calcium. So it's higher levels there. Bring it all together. A diagnosis finding of acute glomerulonephritis may be what? Diagnostic finding, a lab result. What are you going to test? To look for the strep in that acute glomerulonephritis. It's that ASO titer. You listened, you got it, good. That's a huge concept. Which complication of peritoneal dialysis is the most important to watch out for, to look for, to be aware of? Remember, peritoneal dialysis means your belly, your peritoneal cavity is your kidney. What complication is most important to be worried about? And that is abdominal peritonitis. Your kidneys, your intestines aren't bothered by that. It is that abdominal peritonitis. What clinical assessment is the most important to report with a child diagnosed with an acute kidney trauma? I had a 9-year-old come into the ER. He was playing hide and seek with his buddies, was running really fast. He turned around and his back hit a trailer hitch. And on his back was this hugest bruise right over his kidney area. And I said, ooh. So what happened? They did lab tests. They found the potassium 6.6. He was a fractured kidney because of the force of him running into that hitch. So it was the potassium that diagnosed it. Actually, his was like 7 point something. He was a sick baby. Actually, 9-year-old. A multi. What should the nurse anticipate for a child who just had a renal biopsy? Remember, we treat them very similar to cardiac cath here, except remember, this is a kidney. We're going to watch out for abdominal distension. We're going to watch that dressing. We're going to watch for bleeding. We're going to watch for oozing of urine. We're going to monitor intake and output because it's a kidney, and it's bed rest 24 hours. No ambulation. We don't want to bust that clot. We don't want to create issues. We want to protect that kidney from oozing anything. We want it to heal. What would you do if the fluid draining from the peritoneal dialysis has changed color and it's cloudy? So remember, if that has changed color, probably we're getting infected for whatever reason. It doesn't, if you've done bad technique or whatever, sometimes it just happens. Number one, notify the provider because you are going to give antibiotics. I mean, it's better to give than not to give. That's all you have for a kidney because kidneys don't work. There's no other choice, especially in your younger children. So you have to make sure we protect that belly, that peritoneum. And last question, what would the nurse provide to an infant that cannot eat normally? They have tracheoesophageal fistula, esophageal atresia. They cannot eat. What do we need to do for the comfort? How to decrease stress in an infant? And that's the pacifier. Remember, they explore the world through their mouth, but they decrease stress by their mouth. And if they can't eat, at least they're sucking and they're going to be happier. Good job. Here we go. Mavis, good job, Mavis. Kim, good job, Kim. Number one. Sheila, good job, Sheila. Whoop, whoop. Kayla and Ari. So that is my lecture for tonight. We did really good with our timing. Remember, we have an exam in week 10, and we are going to be starting our reviews next week. As always, I'm going to do mine Tuesday at 4 p.m. Of course, you'll get those reviews as quick as possible. Anybody who wants a review by themselves or with 2 or 3 or 6 of you, just let me know. I am more than willing to do that. Any questions regarding your assessment project?
Yes. Do we have to turn it in for you to review like all together or separately? Because I have the first.
Whatever you want, turn it in one by one. I can keep track of it. You can turn in multiple submissions on the modules. I would prefer if you put it in the module, I can see it there. When it's the email, it's harder to track for me, okay?
Okay.
But yes,
Thank
I'm there
you.
to help you. I'm there to make it the best grade that you can get for it, okay?
Thank you.
Well, everybody, I wish you the bestest, happiest, gobble, gobble, gobble. Happy Thanksgiving. I'll be cooking like a crazy person down here. So I'm going to have that Jamaican Cuban fiesta, and it's going to be great. So from my family to yours, have a great one. Thank you, guys.
Thank you.
Same to you, Professor.
Miss